All the advances in medicine are made by research. We've just performed a study in which we looked at partner burden. And the burden of a partner with celiac disease was equivalent to that of someone who is a caregiver of a cancer patient or an Alzheimer patient. So this research is being done, and there are very important issues that can be addressed, but we need to know what they are. Now, wheat is a very valuable grain, believe it or not. There is a lot of nutrients in wheat, but it's the protein part that's bad. So, as we all know, gluten is the term for this storage protein of wheat, rye, and barley. And those other grains, oats, rice, etc., you can see from this diagram of the genetic tree of the grasses are distantly related to the three toxic grains. And these grains are safe for people with celiac disease. So what are the gluten-related disorders? Wheat allergy, that is really a pediatric disorder. There's the autoimmune celiac disease. And then there's this entity of PWAGs, people who avoid gluten. Some of these people have a gluten sensitivity. Other people are avoiding gluten for unclear reasons. And then there's some other disorders that I'll talk about. So to get celiac disease, you've got to have the genes, and you've got to be eating gluten. But 40% of us have the genes, and 99% or more of the population are eating gluten. So that leaves us to explain why only 1% of us get celiac disease. And therefore, the environmental factors appear important. Now, what are these environmental factors? Because there's potential for celiac disease to affect 40% of the population. So not only do we have to cure celiac disease, we actually have to prevent it. Because if it's in your family, it's in your family forever. And we don't know why this epidemic is occurring. It does not appear to be related to breastfeeding, in that breastfeeding is not protective. It's protective for many things, but it doesn't protect children from getting celiac disease. And it doesn't matter when you introduce gluten to children. Two very large studies giving a little bit of gluten between 4 to 7 months, which was thought to be protective, was shown not to be protective. And delaying gluten introduction to after 12 months does not appear to be protective. In these studies in which family members were involved, it was purely related to the dose of the gene, related to the risk of the child getting celiac disease. The amount of gluten given after the first year may be important. Being born by cesarean section is a risk factor. Rotavirus infection in children, and the troops that got Campylobacter infection in Afghanistan and Iraq had increased risk of developing celiac disease. Being born in the summer in the Northern Hemisphere is a risk factor. Antibiotic use is a risk factor, so all of us have to hope and pray that when you take your child to a pediatrician that they don't get an antibiotic. The use of iron supplements in pregnancy appears to increase the risk of the child getting celiac disease, and proton pump inhibitor or the family of the purple pill increases the risk. But we don't know why people get celiac disease from age 2, or I saw a patient at 87 just got diagnosed with celiac disease. These risk factors that are listed here suggest that it may be our microbiome that's important. You know, the bacteria, when I went to medical school, we used to call it normal flora. They were the bugs that live in us and on us and with us, and we evolved with. But now this is called the microbiome. And all of medicine now is talking about the microbiome, so it's going to be interesting to see in the next 20 years where this finishes out. Now, how common is celiac disease? So, the only national standard of our health in this country is this NHANES study, which is the National Health and Nutrition Examination Survey, in which about 5,000 individuals each year are enrolled, and they're studied and questioned. and they have specimens submitted. And so when you get your bone density test done, the standard is tested against the NHANES standard. And so about 8 years ago, they asked individuals, do you have celiac disease? Do you have doctor-diagnosed celiac disease, or are you on a gluten-free diet? And then 10,000 blood samples were tested, and the results were then extrapolated to 300 million people. And overall, 0.7% of the population had celiac disease. It was 1% of white people. Interestingly, about the same number of people who actually had celiac disease were on a gluten-free diet. But what was most important was that only 17% of those with celiac disease, and that was none of the children, had been diagnosed. Now that rate of 17% is one of the lowest in the developed world. 17% of the 1%. In Finland, it's 70% of the 1%. In Australia, Italy, Ireland, and Scandinavian countries, it's approaching 30 or 40%. So when people get diagnosed with celiac disease, they go, what is that? If that happens in Australia or Sweden, people say, oh, I was wondering when someone was going to get picked up with that. There's a great awareness in the population and amongst physicians. This is a study done by Joe Murray. In the yellow box, that's serum that was taken 50 years ago by 20-year-old white men going to the Korean War. And when that was analyzed recently, 0.2% had celiac disease. Then if you take in the black box, 70-year-old white men, or the red box, 20-year-old white men in Minnesota, it's 1%. So this has increased 4 to 5-fold over 50 years. And as I said, potentially that graph could be going up and affect about 40% of us. But in this country, we have this gluten paradox. We have in the red box, red circle, all those with celiac disease who are not on a gluten-free diet. And then we have all these people in the country who are on a gluten-free diet for unclear reasons, and it only overlaps where that 17% exists. I put this slide in last night because I heard that the patient said that they had a delay in diagnosis. This is not new. It is changing. You know, more than 10 years ago, we did a study showing the mean duration of symptoms was 11 years. But this is all around the world. 30 hospital clinic visits in Northern Ireland, 8-year visits prior to diagnosis in Germany. And in Finland, where they know all about this condition, 30% of the individuals diagnosed had greater than 10-year diagnostic delay. Now, our recent study showed that that mean of 11 years has gone down to 4 years. So it is improving, but there's a great lag. Now, we've been very interested in studying why the delay in diagnosis. And there are various things that we can look at. You know, patients might not go to the doctor. They might go to the wrong doctor. The doctor might do the wrong test. We were interested in going to this website, which had the medical curricula of about 40 medical schools on it. And so we searched for celiac disease, and we found that celiac disease was mentioned as often as Wilson's disease. Does anyone know what Wilson's disease is? I've seen 3 patients in 40 years, so I'm an expert at it, because that's 2 more than most of my colleagues. So patients get pissed and angry that their doctor didn't diagnose them, but you can't blame a physician for not knowing something about which he was never taught. So it's a medical education problem in this country, and it goes to many reasons. Like, educators don't work in celiac disease because you can't get funding to do your research, and to be an educator, you should be doing research. There was a study in Finland that showed by educating primary care doctors, they increased the rate of diagnosis of celiac disease. So the answer is doing research to educate the doctors. Patient support groups have been trying to educate doctors, but they cannot do it. They cannot do it. It's got to be done through good research. Now, why is celiac disease important? It's important because it has a significant increased mortality risk. The general population in studies dies at a rate of 1, right? That's where the little asterisk is. So all these studies show that people with celiac disease have an increased mortality risk. Now, how do people get diagnosed? So first of all, patients have got to go to the doctor. Women go to the doctor, right, and get diagnosed with celiac disease. Men don't go to the doctor. Men go to the doctor. Males go when they're children and when they get old and get sick. Women have this compulsory healthcare system called gynecologists that may or may not prolong their life, but that gets them into the doctor and gets them with all these diagnoses. So then the doctor has to think about celiac disease, has to do the appropriate blood tests, refer for a biopsy to diagnose celiac disease, then start a gluten-free diet. Now, the mainstay of the blood test is this tissue transglutaminase antibody, and it's a fantastic test. It is one of the best tests in medicine. I don't know of any other test that has such high specificity and sensitivity, but it's not 100%. The positive predictive value of a test depends upon what the population prevalence is. So in the general population, if you do this test, it's only going to be right 30% of the time. If it's a high-risk group, like someone with diarrhea or family member, it's good about 80% of the time. So these tests that we'll learn about this afternoon, they're skewed to not miss anyone. But that doesn't mean that everyone who's positive is going to have the disease at all. So it's a screening test. So that's got to be remembered. And the mainstay of diagnosis is a biopsy. I find it very difficult to advise someone to go on a gluten-free diet for their entire life and have all their family members tortured by having blood tests done every 3 to 5 years without there being the presence of villus atrophy. There's an early stage of celiac disease that is caused by many other things, and people may get a false diagnosis even after a biopsy. A biopsy is necessary because you cannot prove celiac disease without it unless there are very strict circumstances. You need to have this villus atrophy. There's implications for mortality and the presence of other diseases, the need for follow-up and the need for screening family members. And when you have the endoscopy for the biopsy, you may pick up important other pathology. And it's a baseline to document healing. So no biopsy, no definite celiac disease. Sometimes very probable, but no definite celiac disease. And the pediatric guidelines that have been proposed to be used in Europe are very strict. Symptoms, blood test positive at a very high level, presence of the gene, another blood test done at another time with a more specific antibody. So the presence of one positive tissue transglutaminase antibody is not enough to put people on a gluten-free diet their entire life. Now, I just want to touch a little bit on gluten sensitivity. I look at the New York Times like 20 times a day, and in the last year, there have been like 5 articles on gluten and gluten sensitivity. So there's a lot of awareness about this in the general population. And a lot of it's been pushed along by the pseudoscience of books like The Grain Brain and Wheat Belly, that is pseudoscience. And then famous people, diet people, getting on the bandwagon and pushing this gluten-free diet. Now, all around the world, the celiac disease experts about 10 years ago were seeing patients who had self-identified as being gluten sensitive. And we couldn't work this out. Like, what is this about? So these people in Australia, Peter Gibson and his colleagues, did this study in which they took self-identified gluten-sensitive people with irritable bowel syndrome and put them into a double-blind randomized placebo study. And as this graph shows, the people that had this self-identified gluten sensitivity, they appeared to be right. They appeared to, in this blinded way, be able to recognize they were getting gluten in so many different parameters: pain, bloating, tiredness or fatigue, wind, which north of the equator we call gas, all appeared to be increased in these people. So voila, the patients seemed to be right. But then Peter Gibson and his colleagues put these people on a low FODMAP diet, right? And then did the same study, and the patients couldn't detect it. So the gluten-sensitive patients in Australia were basically FODMAP sensitive, which are the things in your diet that causes gas. A low FODMAP diet, we'll advise that in many different conditions, and it stops the gas and bloating that's so common in irritable bowel syndrome. Takes out the beans, takes out the garlic, takes out the onions, etc. So this low FODMAP appeared to be helpful for people who are gluten sensitive. And so this was all around the media. Researchers who provided key evidence for gluten sensitive now have thoroughly shown that it doesn't exist. But it does exist to an extent, but not that commonly. This is another study from Italy that took patients who were gluten sensitive and not FODMAP sensitive and without celiac disease, and did a double-blind crossover kind of study, and only 3 of the 60 patients were gluten sensitive. So gluten sensitivity or non-celiac gluten sensitivity appears to exist. Most of this is self-diagnosed. Most patients come, and they come to us at the Celiac Center at Columbia University saying, I went on a gluten-free diet and I feel better. I might have celiac disease. Now, I first saw that in people who went on the Atkins diet, which is a low-carb diet, and they came along and they said, I think I had celiac disease, and many were right. They had celiac disease. The other circumstance that they come to a celiac center is they say, I am gluten sensitive, I know that, but I still have all these symptoms. And that's when we find out that 50% of them, we can make an alternate diagnosis. Now, what about all these athletes in the gluten-free diet? So this study from Australia looked at 900 world-class athletes from North America, USA and Canada and Australia, and 40% of them were on a gluten-free diet 50 to 100% of the time. And it was like the coaches getting them on it perceived health benefits. So they did a study in which they got 13 competitive endurance cyclists and put them on a gluten-containing versus a gluten-free diet and studied their work output, and it was no difference. So that's a myth as well. So what's wrong with going on a gluten-free diet? You know, it's a lifelong prescription. You need medical follow-up. There are implications for family screening. There are a delay in other diagnoses. There's cost and consequences of a gluten-free diet. And then it's very difficult to know what to do as a physician who's caring for these individuals about what the patient really has. For more than 20 years, I've been holding my hand out to patient support groups saying the only way to advance this condition is to advance research. And at last, the Celiac Disease Foundation has stepped up, so I heartily thank you all.